Thank you, everybody, for coming to the hearing this morning. We were going to do a business meeting first. We do not have the necessary requisite number of members of the committee in order to conduct the business, but and one of our new members has got to leave to go to a markup in Homeland Security. But I would like to have an opportunity to welcome Bob Turner from the 9th District of New York, where he's been a lifelong resident. 40 years in the television industry, leaders in large and small businesses, and a veteran. And we welcome you to this committee. And Mr. Turner, you're recognized for any remarks you may wish to make.
Thank you, Mr. Chairman. It's a delight to be here. I'm very proud to serve on the Veterans Committee as a veteran, lo those many years ago. But there's a lot I haven't forgotten, I will discharge these responsibilities with enthusiasm. And thank you. I yield.
Thank you, Mr. Turner. Mr. Donnelly.
On behalf of all the Democrat members, we want to welcome you to the committee and thank you for your service to our country. We are in your debt for that and look forward to having you as part of the team here.
We have another new member, or will, once we do hold our business meeting, but Mark Amadei, who is from the 2nd District of Nevada, which actually covers most of the entire state, but he is also a veteran, a JAG officer in the United States Army. He was a state senator in Nevada before he came here in a special election, so without question, we welcome another veteran to this committee, and would yield to Mr. Donnelly also.
And we welcome you as well. I want to thank you for your service to the country. We're proud to have you here, and you'll find this is a committee where people don't really even think about politics. It's how can we serve our veterans, and so we look forward to having you as a great part of the team.
Mr. Amadei, do you have any comments you'd like to make to the committee? You're recognized.
Thank you, Mr. Chairman, I will, following the lead of my co-classmate from New York, I would just say that I'm actually proudest of being the father of a Gulf War veteran, my daughter, who served in the Navy for 4 years, so I look forward to working with everybody on the committee, and I yield back. Thank you, Mr. Chairman.
Thank you very much, and at a time when we have enough members, we'll go ahead and make the assignments to your committees. We understand that people are having to go in and out. We do appreciate you being here this morning. I would like to go ahead and ask the witnesses if they would go ahead and come forward to the table. Because of some of the detail that we're going to be covering in this hearing today, I gave great thought long and hard about deviating from a standard practice of this committee, and that was requiring that you be sworn in as witnesses. I don't think that's going to be necessary this morning. I trust that each of you would and will provide nothing but truthful and complete answers to this committee. That being said, we're going to be listening. I reserve the right to swear you in at any time in the deliberations this morning. Is everybody clear? Some of the issues plaguing the VA Medical Center in Miami are not new to this committee. Members of the Miami delegation, including the chairman of the House Foreign Affairs Committee, Ms. Ross Leighton, have been talking with me on a regular basis about the medical center in Miami. But it came into the spotlight in 2009 when it was discovered and reported that endoscopes were not being reprocessed correctly, placing over 2,000 veterans at risk of exposure to disease. Nearly 2 years later, after the initial round of notification, 12 additional veterans have been identified as being at risk of exposure. And I think all of us would agree that putting any veteran at risk is not acceptable. But failure to identify and notify everybody at risk because patient log books were logged away in a safe is almost impossible to believe. I only say nearly impossible because that is in fact what occurred. The issues we're going to discuss today extend well beyond sterilizing reusable medical equipment. At the heart of this issue is leadership at the VA at all levels and in all parts of this great country. It's my belief that the failures in leadership and patient safety that were brought to light in 2009 are still occurring today. Multiple investigations have taken place, disciplinary recommendations have been put forth, new processes and procedures developed, new policies established, yet problems still exist and have not been fixed. Earlier this year, VA told this committee in a briefing that things were running smoothly in Miami. However, the VA Inspector General released a report in August detailing how in one case, 50% of the facility employees still failed to properly sterilize reusable equipment. Recent news reports are also troubling. For example, this summer we read about an Air Force veteran who was brought to the Miami Medical Center from a neighboring hospital, Jackson Memorial. The veteran had been admitted to the hospital earlier by a friend after threatening suicide. Once it was realized that she was a veteran, she was transferred to the Miami VA Medical Center. The veteran then escaped and committed suicide by a cop just one day after she'd been admitted to a system that should have protected her in her clearly fragile state of mind. In another troubling story released last month, the Miami Herald reported on its findings contained within one of several administrative investigative boards. This board was conducted in the wake of the colonoscopy equipment cleaning problems and subsequent notification of veterans. And as the Herald noted, disciplinary action was recommended for a lack of oversight by hospital leadership. The article also noted that the hospital's director, who was reinstated less than 2 months after the report's recommendations were completed, and that VA declined to comment on what actions were taken based on those recommendations. It is this committee's desire that today's witnesses outline a clear process for VA's leaders in preventing and fixing failures that compromise the safety of veterans. The committee also needs to hear about how a stricter and comprehensive process can be put into place so that necessary information flows to all levels at VA, from the local level to the network level to the central office. We know that currently there is much that goes unreported, and given the public repeat offenses, a solution from VA is overdue. VA must also outline how compliance with department policies is enforced. If employees are circumventing patient safety procedures, they have to be held accountable. If policies made by central office can easily be circumvented, then policy makers at VA must be held accountable and meaningful enforceable policies put forth. A related expectation by the committee is that existing VA policies in place can and will be followed by all employees. If policies are disregarded or willfully ignored, there should be enforcement mechanism in place and the right people held accountable. Otherwise, policies become words on paper and a little more. An important point to keep in mind throughout today's hearing and moving forward is that the problems we are discussing are not limited to Miami or even to VISN 8. The committee is well aware of similar problems at medical centers all across this country. More than once, VA has come to us and said problems at its facilities are fixed and all is at well. More than once, that has been shown not to be the case. The Miami facility is one glaring example of this national occurrence. Just as it should not be acceptable to Secretary Shinseki to be told one thing about how VA facilities are faring only to be subsequently told otherwise, it is beyond unacceptable for that to occur before this Congressional Oversight Committee. All of us must be vigilant in rooting out misleading or incomplete information that only serves to keep the truth from full view and ultimately harms those who all serve in a common mission, the veterans of this country. I appreciate everyone's attendance this morning. I now yield to the ranking member, stand-in, I like you, for an opening statement.
Thank you, Mr. Chairman. I like you too. Patient safety should always be the VA's top concern. Our veterans go to our hospitals because they are one of the best in this country. And obtaining optional health care, optimal health care, should not come at the cost of veterans' health. Veterans trust their doctors, but what they might not trust is the system. And when they get the news that there has been a data breach and their personal information might have been stolen, or the news that they are at risk of contracting diseases because staff did not properly sterilize reusable medical equipment, veterans rightly lose trust and start to have concerns. Even when these or other incidents come to light, we often find out that they could have been prevented if hospital administrative officials would have implemented proper guidance or enforced protocols to avoid significant breakdowns of patient safety. Many questions come to light with the many recent issues at the Miami VAMC, particularly the veteran's suicide 2 months ago, after that veteran was not held the mandatory 72-hour VA-required evaluation period. Taxpayers are also curious to hear why this facility is running under a $30 million budget deficit. While the committee has examined these issues in both the 111th and 112th Congresses, today we have the opportunity to hear from a hospital director who has witnessed this firsthand. I hope that we will be able to receive insight into the experiences at the Miami VA Medical Center with the delays that occurred in notifying individuals of contamination, what led to these delays in a notification to 79 veterans, and what the Miami VAMC is doing to correct previous deficiencies and improve patient safety. Mr. Chairman, I look forward to this morning's testimony, and I yield back the balance of my time.
Thank you very much. Our first and only panel that we're going to hear testimony from today is Mr. William Schoenhardt, Deputy Undersecretary for Health and Operations and Management in the Veterans Health Administration. In this position, he is responsible for VA's 21 Veterans Integrated Service Networks, or VISNs, including their operation and their administration. Mr. Schoenhardt is accompanied by Mr. Nevin Weaver, the Director of VISN 8, which encompasses much of the part of Florida and parts of southern Georgia. Also accompanying Mr. Schoenhardt is Ms. Mary Baracall, Director of the Miami VA Healthcare System within VISN 8. Mr. Schoenhardt, your complete statement will be entered into the record as a part of this hearing, and you are recognized for 5 minutes.
Thank you, Mr. Chairman and members of the committee. Good morning, and thank you for the opportunity to appear here to speak to CARE regarding the Bruce W. Carter VAMC in Miami, Florida. As Congressman Donnelly and the chairman emphasized, patient safety is our first priority. What is in the best interest of our patients in any hospital, certainly in a VA hospital, is to provide a safe and effective treatment for all of our veterans. And as a veteran myself, I take this responsibility very seriously. The written statement that we have submitted speaks to a lot of detail regarding the actions and events of Miami. But I would like in these few brief minutes to back away from that a little bit and speak more from a national perspective regarding the issues that particularly the chairman rose. We really find in patient safety, both in the private sector, where I had 35 years of experience before coming to VA, as well as in the public sector, that there are three essential elements to providing safe patient care in a hospital. First is to do all we can to prevent harm. Second, to develop a culture of safety, psychological safety, where people can raise concerns. And finally, to hold leaders accountable to ensure a safe environment. Let me just speak a little bit to each of those. First and foremost, we have an obligation to do all we can on a continuous basis every day to prevent harm in our nation's hospitals, and particularly those that serve our veterans. Through systems, processes, training, equipment, all that we know in healthcare can be applied to ensure safe, consistent care. We have an obligation to do that. This is a job of continuous improvement. You will never hear me say we have arrived and the destination is arrived. This is a journey that requires continuous improvement as new technology, new process, new insight, both from practice within VA as well as outside of VA, are brought forward. That's why root cause analysis, RCAs of serious events, trending our issue briefs, the development of investigative boards to do fact-finding when we have breakdowns in care are so important. And that's what we are obligated to do, is first and foremost ensure that we provide preventative care, safe care to our patients. This has been facilitated in recent months by a realignment within the VACO, the VA Central Office reorganization, where we now have in operations the SPD, or Sterile Processing Department, operation directly in our line, and I'll speak to that a little bit more. Second major issue is a culture of safety, and I would suggest to you that culture trumps strategy in everything we do. By that, I mean open lines of communication to ensure that people who come forward with concerns, suggestions for improvement, concerns about patient care are heard by leadership, and that follow-up action is taken in a timely and vigorous manner. Also, as has happened in recent months in our hospitals, to empower the staff to stop the line when it's necessary in the interest of care for our veterans. That is to say, when we see something that doesn't look right, to have the courage to stop the line and make sure before any veteran is put at risk that we understand completely what may be in the case of a breakdown in process that needs further study before any patients are put at risk. And leadership needs to support that, and that's certainly a big part of what we need to do as we go forward, and as you see in a number of our hospitals is being fully accounted for. Finally, as the chairman, ranking member have described, holding our leaders accountable. And I would just say, most importantly for those first two things, that is doing all we can to prevent harm in the first place through full implementation of everything we know, both in and without VA, to prevent harm and develop a culture of safety. And secondly, to ensure that culture of safety is evident throughout our organization. Secretary Shinseki, Dr. Petzel, and all of us are committed to accountability, transparency, and full disclosure of all that we do on the behalf of our veterans. That's probably no more evident than in our Aspire program, where we put out those indicators of quality, which I don't know of any system in the nation does, that are indicators of care that we aspire to perfection. And that is an effort that we will continue to focus. So finally, Mr. Chairman, out of our values of integrity, commitment, advocacy, respect, and excellence, we are committed to providing the best possible care to our patients. And we will do this on a continuous basis every day to ensure those who have served our country receive the best possible care in the United States. And we're happy, sir, to answer your questions.
Thank you very much for your testimony and providing a global view of VA and the health care that they provide. Obviously, we are focusing specifically today on Miami. So I first would just like to ask Mr. Weaver, as the VISN-8 director, are you satisfied with where Miami is? And can you tell me where you would recommend improvements? Check your mic too, please, Mr. Weaver. Thank you.
There we go. Thank you, Mr. Chairman. First, I am pleased with the direction that Miami is headed. We have been through a lot of challenges over the last couple years. I think that we have made some of the necessary changes that we needed to do. Having the national leadership develop new programs to provide oversight, are establishing oversight at the network level, including a SPD board of that oversees all of the activities at the medical centers, and also having a number of unannounced visits during the year from my office, and then at the medical center level, the same kind of activity is going on. They have a team that goes in and does unannounced visits and ensures that the training is accomplished, that the policies are up to date, and that the work is being done correctly. In looking at the Miami performance, first of all, at the network level, we have a performance improvement council that reviews performance of all medical centers on a monthly basis. We look at the performance measures that are the standard for VA, and we have the leadership present to us, along with our program managers in our office, talking about any areas that need to be improved. Miami has continued to move in a positive direction. We have relied on Miami to work with other medical centers within our network. We have surgeries that are referred by West Palm Beach to Miami, to Orlando to Miami, and from Bay Pines to Miami. We continue to look at other kinds of opportunities to send referrals to Miami, and areas that need to be worked on are areas of continue to look at administrative processes to ensure that we are working as efficiently and as effectively as possible. The three drivers in our network are quality. That's number one. We will not do anything to compromise quality. We look at those quality measures and performance. We look at the second driver is our satisfaction. We look at patient satisfaction, which has been high. We've looked at employee satisfaction, which continues to be at the higher level. And then the third driver is our cost effectiveness. And we try to do this in a very cost-effective way. And then finally, with Miami, a real positive note is that even though we had a lot of negative publicity over the last couple years, the workload at Miami continues to grow. We continue to reach out to our veterans, and our veterans continue to come to the VA. And those numbers have continued to increase. In fact, they are above the national average.
Thank you very much. I would like to recess the hearing for just a moment procedurally. We do have a quorum present to take care of some committee business. Mr. Donnelly, if that's okay with you. We've already, members introduced our two new members, Bob Turner and Mark Amadei. They both had an opportunity to speak to us, but for the purposes of creating subcommittee vacancies for our new members, I would first like to ask unanimous consent of the full committee to accept the removal of Representative Flores from Texas from the Disability Assistance and Memorial Affairs Subcommittee and Representative Denham from the Economic Opportunity Subcommittee. Hearing no objections, so ordered. I want to thank both of them for stepping aside to allow new members to have an opportunity to participate in the subcommittee process. The list is currently before members, and I would like to ask Mr. Bilirakis, if he would, for a motion for adoption of the resolution. Any objections? No objections, so ordered. Again, welcome Mark and Bob, who has already left. This concludes our business meeting, and I'd like to return back now to our full hearing. Ms. Bearcall, would you like to comment on, since it's your facility, how you feel things are going in Miami?
Thank you, Mr. Chairman. Things in Miami, as mentioned before, are steadily improving. I will note that upon my arrival at Miami, shortly after my arrival, a year, almost exactly, the AIB pointed out a number of areas that had been, or irregularities that had been going on for a number of years. Upon realizing that, what the AIB did, it provided me the opportunity to address those areas with the proper degree of urgency to ensure that we were addressing with specificity the areas of the RME. I will mention that in the RME area, in the sterile processing department, we have done a number of changes. We have changed the organizational structure. We have to have the department reporting directly to the nurse executive. Previously, it reported to the administrative arm of the medical center. We have ensured that the staff that is in that section is of has high credentials to be in that area, and that has a clear understanding of what the things that go on in that area. We have, in addition to that, the individual that leads that area, as well as the nurse educator for the sterile processing area, are certified and instrument sterilization. And we have steadily replaced staff as appropriate to ensure that we are hiring health, operating health technicians to people who are much more sensitive to those areas. There's a number of other things that we have done in the area, including physical restructuring. We have bought all new equipment that is of the same kind of vendor so that it reduces variability in the number of processes that the individuals have to remember. We have provided extensive training. We do competency reviews on an annual basis on these individuals. We have set up an RME committee that reviews the processes. We have the RME committee reporting to the Medical Executive Board, who then reports to the Patient-Centered Executive Leadership Board. Since I will indicate that my mantra has always been to be patient-centered, and I made that clear to the staff from day one, that my decisions would always be patient-centered. My father's a veteran, like several of you, and my father is a physician. So healthcare is something, and my mother a nurse. So healthcare is something that I have been, that has always been in my DNA, if you wish. I am keenly cognizant of the impact of anything that would be less than perfect, in particular for our veterans. I've worked serving the veterans for over 30 years and am honored to have the opportunity to do that, and I take that job very seriously. Our performance measures, in particular our outcomes, would show that we have worked steadily to improve the confidence of our patients in the care that we deliver at the Miami VA. And evidence of that is the fact that we have, as Mr. Weaver indicated, increased the number of patients that are coming to our medical centers. I work very hard to ensure that we are reaching the veteran population so that we can provide proper care to them. In addition to that, to restore some of the confidence that we have in the processes that we are providing to our veterans, we have the number of colonoscopies that are being done at the Miami VA since 2009 have increased by approximately 20%. So I think that we have put the necessary oversight systems in place to ensure that, that we are not placing our veterans at risk. In addition to that, I try to receive feedback from the stakeholders. So I meet often with the Veteran Service Organization members, with members of the Veterans, of the PBA, Paralyzed Veterans of America. I am in communication. I've also tried to develop partnerships with the community so that we can ensure that we are strengthening our relationships with the ability to provide the best care anywhere. We, in addition, because some of the questions have arisen about whether or not we hold staff accountable. And I believe that, that we do hold staff accountable when there are areas that have not been properly addressed or addressed as we would expect. We have set policies in place, and when members of our staff deviate from those policies, we have a variety of areas that we, systems that we put in place to review each instance to ensure that, to understand what happened. So we have the root cause analysis system, as has been mentioned previously. We also have the administrative investigation boards. It is my policy to always start by looking at the process, because I believe that if we are able to fix if there is something wrong with the process and we can fix the process, we will be able to standardize the care that we provide, and doing so diminish the number of errors that might happen. In addition to that, whenever during the process of a root cause analysis we determine that there has been some degree of negligence or something that reflects poorly on the conduct of an employee, we do, in most cases, we establish either an administrative board of investigation, or if the facts are fairly clear, we might do a fact-finding. And in conclusion of that, then we would take the necessary actions to discipline employees or to train employees or whatever it may call for. In terms of patient safety, I may tell you that the Miami VA has received in the last 3 years, has been recognized by the National Patient Safety Center for the completion and thoroughness of their RCAs. We received the Bronze Award in 2008, the Bronze Award in 2009, and the Gold Award in 2010. We have also been recognized by external bodies. We hold ourselves accountable for the type of work we do, and as such we get oversighted not only by this committee, but by many internal and external bodies. We received probably on the average of, I believe it was over 30 visits in the past year. And in each of those visits, there might be some findings.
If I could, and thank you, we'll have an opportunity to discuss more, and my time's pretty much expired, but since you brought up the issue of root cause analysis, in my opening statement, you heard me talk about the suicide by cop. Are you familiar with the issue that I'm referring to?
Yes, sir.
Okay. It's my understanding that this individual was an Air Force veteran, had in fact told her family and friends that she was going to commit suicide by cop and was acting very irrationally, was taken to Jackson and Baker acted. Is that correct?
That is correct.
And from that point, once Jackson heard that she was a veteran, she was transferred to Miami. Is that correct?
That is correct.
So this individual was involuntarily committed through a Baker Act, correct?
There was some confusion as to whether it was involuntary or voluntary.
But she was Baker acted into Jackson, correct?
Correct.
That's involuntary, correct?
Correct.
Okay. Where was the confusion?
In the communication between Jackson and the VA, there was initially some miscommunication about whether she was being transferred on a voluntary or involuntary. A full root cause analysis has been done on the case, and they had found several things in addition to the root cause analysis. There are some areas that we have conducted a fact-finding to determine. As you know, the root cause analysis is basically focuses on processes and doesn't allow us to utilize that information to take the necessary action on individuals.
So it's your recollection that Jackson did not inform you that she had been involuntarily committed?
My recollection was that there was some verbal communication which was not clear, but that upon
is that normal that it's done verbally on somebody that's been committed to another facility?
I cannot speak that if it's normal. I know that upon arrival of the individual, the papers indicated that it was involuntary.
Jackson's papers indicated it was voluntary, or VA's papers indicated it was voluntary?
Jackson's papers, when they came in, indicated that it was involuntary. So the verbal communication was that it was voluntary. The paperwork upon receipt was that it was voluntary.
So
was my recollection.
She was Baker acted. Jackson informed you she was Baker acted and involuntarily committed. And then she walked out the front door, shot a cop, and was killed.
The resident that was there at the ER at the time interviewed the veteran extensively, and
it doesn't matter at that point because there was paperwork saying that she had been involuntarily committed. Is that correct?
That's my understanding. And the resident then spoke to the patient, and at that time determined that they would that it was going to be a voluntary she felt comfortable after interview that it would be a voluntary
Oh,
admission.
so she can be Baker acted and then unbaker acted, and then can walk out the door and be killed.
I cannot.
Let me ask you this. What would be the difference, and I'll ask Mr. Weaver, reporting requirements from the hospital to you at the visit, and I apologize to my colleagues for the lengthy question. If this person had been involuntarily committed and it had been communicated as such, and this person eloped or escaped or walked out from your facility, was killed by a cop after saying that she was going to commit suicide by a cop, would that be something that would be reported to you, and how was it brought to your attention? How did the hospital handle the communication?
Okay. Mr. Chairman, we were notified immediately of the situation, and
how what did they say had occurred? This person had voluntarily committed themselves and walked out?
The person had, I believe, involuntarily committed themselves, and as Ms. Barakal mentioned, mistakes were made. The response by the staff was not appropriate. The issue is that we looked at an RCA looking at the process, but we also looked at individuals who were responsible for and we held them accountable. I think that anytime a patient is admitted, we have to do our due diligence and make sure that the patient remains with us and is safe and secure, and that we respond appropriately by having the person placed in the facility, in the medical center.
So was this a failure or not a failure?
I think the event was I think a failure.
And somebody has in fact been reprimanded for the failure?
We have done a series of things. We recognize that there were, some process failures through the RCA. In addition to that, we recognize that there were some failures of individuals to follow, the policy. To follow what to conduct their job appropriately. What we have done is we've addressed the process issues. One of the main things that they
has anybody been disciplined for this veteran being allowed to walk out of a hospital after saying they were going to commit suicide by cop, allowing her to pull a gun on a police officer, shoot the police officer, and being killed by that police? Has anybody been disciplined at your facility?
I have taken the people out of the position, and the fact finding
Well, they still have a job.
The fact finding is being finalized.
They still have a job.
Sir?
They still have a job.
As of today, they do. They're not in that position, and the actions have not been finalized. But because I'm in the middle of the deliberations with the fact finding, there are strong actions being taken.
Mr. Donnelly.
Thank you, Mr. Chairman. I have a question regarding Dr. Vera in the green notebook with 79 names in it. Are you familiar with the 79 veterans who were not contacted? That information had been put in a safe? Ms. Barakal, I'm sorry.
Okay. The logbooks had been reviewed in the initial review of the endoscopy and trying to make identification of the veterans. And when they reviewed the logs were determined to be inconclusive. It didn't have complete information, and because it didn't have complete information, it was determined by clinicians that it wasn't a reliable source of information.
What was Dr. Vera's explanation for those 79 folks not being contacted and their names being in a safe?
So what we did with it was that as soon as we learned about it, and I think that this is an important piece to know.
Well, what I asked you was, what was his explanation as to why that happened?
Because at the beginning, when they reviewed the logs, they determined them to be an unreliable source of information to determine which individuals were affected by the endoscopy event. And it was determined to be an unreliable source because it was incomplete. These were handwritten, names were incomplete.
So did he not believe those 79 people had suffered possible contamination?
No, at the time, the 79 individuals had not been identified.
But their names were in this book.
What had happened was actually there's two. The 79 is it was the result of a patient coming up with a letter.
There are two different events that happened. One with the logbook, and others were already in the system. The logbook was identified. There was a decision made in combination with the medical center, the network, and central office that the logbooks were an unreliable source. The logbooks were composed, were in various clinics. And by the way, the logbooks are no longer in existence. New logbooks do not exist anymore because they're not allowed to use them.
Did you feel you had any reliable source? That the logbooks are not a reliable source?
Yes. The computerized patient record was a reliable source, and that's where most of the data was mined to get the first list. The logbooks came on like the third stage. The second part was the 79 individuals that were identified. They came when the clinicians went back and started looking at data again. What prompted that was a patient came in, said he was not identified. So they went back and they started to look, and Ms. Baracall can explain that process.
Yeah.
So the source, though, the source that you had, the computerized patient records that you said was the reliable source, didn't even include these 79 people. Is that what you're saying?
Yeah, no, it did.
Well, if it did, how did you not have these 79 people?
What has happened in that process, if you would allow me to walk you through the process, when we originally looked at trying to identify all the patients, we utilized we had contacted central office, and we had received the look back manual, which gave us some guidelines as to how we go about a look back. So we identified as many individuals as we could by utilizing a series of methods, which in fact even enhanced the methods that were in the previous look back. And that allowed us to identify the biggest cohort of people that were at potential risk.
Well, what were the holes that you couldn't find those 79 people to start with? I mean, here they are walking around at possible risk.
So we continued to enhance our methodology by bringing additional experts to enhance the methodology further and further and further. So we continued to refine the methodology. We thought we were completed in that process. And one of my residents received a letter from a veteran indicating that he had not been identified and that he had had a colonoscopy during that period of time. So that letter, and I think this is important to note because it speaks to the culture that I have worked so hard to establish in Miami, and that is one where people will stand up whenever they find that there's a problem, and we will stand up and take responsibility for it and do the right thing on behalf of our veterans.
But how did we miss the 79?
Correct.
To start with?
The 79 individuals, as a result of the letter that we received,
okay, I understand the letter. My question is, how did we do all these enhanced methodologies that you're talking about, and we still didn't even know we had 79 folks we missed?
Yeah, okay.
What happened was when they went through the process of going to the computerized patient record, there were pages in that were behind pages that they were looking at, and they found that they had not drilled down far enough, and that's when they started to look at that process and started to drill down further and found out that there were 79 additional.
So I guess the question comes down to, were they in the records, but we missed them, or were they not in the records? Like, were the pages stuck together? Is that what you're saying?
The particular patient had had more than one procedure at that time.
Yeah, yes, the answer is yes, it was in the record.
And we missed it.
It was in there, but they had not drilled down far enough because of the way the record's set up to identify those 79 individuals.
Mr. Chairman, my time is up. Thank you, sir.
Thank you, Mr. Johnson.
Thank you, Mr. Chairman. You know, I've reviewed the materials that have been compiled for this hearing, and I can tell you that as a veteran, I am extremely concerned. And I can tell you that as the chairman of the Oversight and Investigation Subcommittee, I'm not going to turn loose of this one. There's some accountability that must result, and I'm looking forward to working with the chairman and the full committee to make sure that happens. Mr. Schoenhard, am I pronouncing your name correctly? You talked about holding leaders accountable.
Yes, sir.
I've already heard enough testimony to want to ask you, what's your definition of holding leadership accountable? We got veterans that are escaping the facility and committing suicide. What's your idea of holding leadership accountable? Now, I know in my military days, I know what holding leadership accountable means. What's yours?
Our definition of holding leaders accountable is creating what I said before, the process for ensuring safe, effective.
No. That's holding leadership. That's making leadership responsible,
Okay.
creating processes.
Yes.
What happens when the process fails and veterans die? How do you hold leadership accountable?
In this case, sir, we will, as we are here, doing complete fact-finding to determine what went wrong.
Okay, thank you.
And
Mr. Weaver, in your testimony, you talked about being pleased with the direction that the Miami facility is going. I can assure you, sir, I am not. And I want to make sure you understand that as we get into these questions. Ms. Barracal and Mr. Weaver, you've explained your efforts to continually provide an improved environment of care. VA provided this committee with a document identifying an eventual mock joint commission survey from your facility. Ms. Barracal, are you familiar with this document?
Yes, sir, I'm familiar with the fact that they did a mock survey.
When will you schedule a mock joint commission survey?
What we do is we...
When? Not how, when. When will you be scheduling that survey?
We schedule it, in...
When? Is there a date for the survey?
It's not a particular date. We schedule the
So you haven't done one yet?
We had a mock survey. We were anticipating the Joint Commission to come in last year, and they did, and we were fully accredited at that time.
So you've already conducted the mock survey?
We conducted a mock survey.
When was that conducted?
I don't recall the exact date, sir.
Okay. Well, then, if that survey was conducted, Ms. Barracal, how is it that a radioisotope could be left out in the open and unattended?
The idea of us, again, we are an organization of continuous improvement, and what we are trying to do is identify issues so that we can correct them on the spot. So we are, trying to be in a position of continuous readiness, and that means that we set different processes in place to try to identify issues so that we can correct them.
Why is preventive maintenance not being documented?
So we do EOC, which are environmental rounds. We are doing those now on a weekly basis, and I have one of my executives attend those so that we can be on top of all the different issues to determine what, what is happening.
Well, the results of the mock survey that that has been made available to us was conducted on August 2nd, and it indicates that preventive maintenance is still not being documented. So I'm confused about how your process of continuous improvement is working, because I don't think it's producing the results that America's veterans expect or the American taxpayers expect. Why is your emergency management program not conducting drills and reports?
We've had a turnover on the emergency management.
Since October 2nd?
No, sir.
Okay, all right. Mr. Weaver, these issues are not new. And you talk about being pleased, and Mr. Schoenhard, you talk about holding leadership accountable. They appear on report after report in one form or another. What are you doing to hold leadership accountable for these kinds of failures?
I'll take the first response. Sir, at the network level, we have individuals that have responsibility to go out and do surveys and audits, and we review the performance. We review surveys. We do crosswalks with the environmental.
Mr. Weaver, I don't mean to cut you off.
Okay.
I'm not talking about how your process works. Your process and the surveys that have been conducted and the results of veterans going out and committing suicide after escaping the facility in Miami are evidential. I'm looking for accountability. You've both talked about leadership accountability, and I've not heard either one of you say yet what leadership accountability is being enforced.
Okay. I'm sorry, I didn't answer your question, sir. My approach to this is looking at performance.
Who's been disciplined? You got any disciplinary records as a result of these things that the surveys say still are not being conducted? Who's been counseled? Can you give me a name?
On those specific issues, we have not worked through those yet. A lot of this is going to deal with the performance appraisal process.
I'm familiar with the Civil
Okay.
Service performance appraisal process, Mr. Weaver. That's not going to get it. That's not accountability. Not when patients are leaving your facility and dying. Mr. Chairman, I think I've extended I hope we're coming around for another round of questions because I'm not finished.
We may have 5 rounds.
Okay, thank you. I yield back.
Mr. McNerney.
Thank you, Mr. Chairman. Mr. Schoenhard, do you agree that there's still a problem within the Veterans Health Administration with compliance of established patient safety protocols, policies, and procedures? And if so, what's being done about this?
Sir, we are continually inspecting both at the VISN level and at the medical center level for compliance. And as I said in my opening statement, this is an area that requires ongoing vigilance. And if I might just say earlier in terms of accountability, it's important that our leaders are ensuring that steps are taken to correct deficiencies that occur in Joint Commission mock reviews, that occur in CAP reviews, and the rest. We invite those kinds of inspections. We know they will find things. Where we hold leadership accountable is not necessarily for finding areas for improvement, because we want areas for improvement. What we hold leaders accountable for is ensuring full implementation of those recommendations, and that would extend to this effort as it relates to patient safety.
Well, good. Then what specific actions are being taken to investigate and fix the reported problems at the Miami Medical Center?
Well, let me just go back and say at my level, as the committee I'm sure is well aware, a national AIB was convened in the second iteration where the veteran called and indicated that he had not been notified as part of the initial review. We wanted at that time to understand what happened, because we obviously missed a veteran. We wanted to understand what more veterans might be at risk that were missed, and we wanted to understand, not just for Miami, but nationwide, what we could learn from this experience. Because if we had a glitch in the initial review, we missed a veteran in Miami, we could have done that elsewhere. Part of also what I wanted done were recommendations regarding whatever corrective action might be taken. And there were, as a result of this AIB, disciplinary actions taken with regard to local leadership. I might just add that when the initial report came back from the board, it was moot on the subject of whether at the VISN level or at VACO level, at our level, there was a lack of leadership and accountability with that first disclosure.
Well,
and I charged them to go back and come back with information.
I'm surprised that we're here again today. I mean, the problem is, in my mind, that there are specific issues at the Miami Center.
Right.
But how does this reflect across to the other centers in the country? Are we just looking at the tip of an iceberg here, or are we really talking about an isolated set of cases that involve specific performance at that facility?
Well, I think that every facility varies in its level of performance. And the reason that we are here supporting Mary Baracall and her leadership is that she's turning this ship around. It takes time to change the culture. It takes time to be able to ensure that people are held accountable at the local level and that we really are patient-centered. And if I did not believe, if our leadership did not believe Mary Baracall was making improvements, we would not be supporting her leadership in place there.
Well, I mean, I've been to many hearings of this nature, not many, but I've been to hearings of this nature, and there's times when you get the feeling that, yes, things are moving in the direction they need to move in. There's times when you don't get that feeling, and that's the case we're in right now. I just don't get the feeling we're moving in the right direction. But it worries me because I want to make sure that this isn't something that's more broad and that could have bigger implications for our nation's veterans than the bad enough case that we're seeing in Miami.
Well, sir, I can assure you, at the VISN level and at the central office level, we continually monitor the operation of our facilities. And I know there's been some question about whether we get ground truth, and part of what we are working very hard to ensure is timely reporting and accurate reporting. We're making great strides in that respect. And that again comes back to the culture, comes back to an accountability to ensure, first and foremost, that the Mary Baracalls of our system, the medical center directors, have full visibility of issues. You cannot solve what you don't see. And that's what Mary is turning around in Miami.
So you're saying that Mary didn't see these problems from her position?
I think, frankly, there has been a culture in Miami. This varies from institution to institution, both in VA as well as it does in the private sector, of a culture that did not have the psychological safety that Mary is bringing to it. That there would be, typically when we have problems in healthcare, whether it's in the private or the public sector, it can be sometimes the case that people bring forward concerns and leadership doesn't act. That's back to Congressman's question, what I hold people accountable for. I don't fault that there is opportunity for improvement. What I fault and hold accountable are leaders who don't act on that information and improve care for veterans, and don't create the conditions whereby people can freely come forward without recrimination and be heard and supported on behalf of our veterans.
And so have people come forward and been recriminated?
Excuse me, sir?
Have people come forward and been recriminated in Miami?
No, but that can happen, or that can be perceived. And one thing that I've learned in the last 2 years at VA is that there's been considerable concern in the past regarding whether people can freely come forward without recrimination. I've had a number of members express concern to me about that. We are working very hard in keeping with our values to ensure accountability and transparency. And the first thing I would hold a leader accountable for is creating a culture where we know what's going on and that we act on it. Because there is always opportunity for improvement in any hospital that serves patients.
Thank you. I yield back.
Before I recognize Dr. Benishek for the next question, I just find it troubling that you have said that the Miami VA Medical Center is moving in the right direction. We extrapolated some of the numbers, and I apologize, it's maybe a little difficult, but I think you kind of get the gist. In fact, here it is. They're showing it up on the screen. Senior management satisfaction down. I mean, the ship may be going in the right direction, but I think it's sinking. Psychological safety down. These are your numbers. Customer service down. Overall satisfaction down. I mean, that's not the direction that any of us want to see our medical centers heading. Dr. Benishek.
Thank you, Mr. Chairman. Mr. Schoenhardt, what is the average tenure of a director of a medical center?
Sir, I do not have that information, but we can provide that.
Mr. Weaver, would you happen to know? In your vision?
In my network, it's not very long.
Ms. Barako, how long have you been the director of the VA, of the Miami?
It will be 4 years in March.
And you say you started just a year before this incident?
Yes, sir.
But where were you before that?
Before that, this is my 6th VA. Before that, I was in Los Angeles.
And how long were you there?
About a year and a half. Or so.
And the place before that, how long were you there?
I was in Loma Linda, California for roughly 11 years or so.
But that was not as a director.
Before, no. I was the
Mr.
associate
Schoenhardt,
director.
This is the point of my questioning is I worked at a VA hospital for 20 years, and for that 20 years there was 10 directors. The director lasted 2 years, and then they went on to their next appointment. And in my opinion, the director of a medical center, it takes a while to understand the function of a medical center. And in my impression of what was going on was that people were just biding their time and preparing for their next job. And I think that there's a structural problem in the fact that people turn over rapidly as a director of a medical center because they can't understand their own facility enough to delve into each and every problem like this because they're just preparing for their next job. And I think that particularly is a problem in the way the VA is managed, not from the individual director job. I mean, I think what people try to do the best they can, but with a year being there and then moving on to the next job, it's a problem. And I think it's throughout the system. Can we fix that?
I might yield to Mr. Weaver to speak because he had previous responsibility for workforce and human resources at the central office and has more experience and perspective than I have. But I would agree, it takes time to turn the culture of a hospital.
But it's not the hospital, it's the administrative people that are switching these people around on a every other year basis so that the person is not invested in that hospital and that can't get to know that facility as well as they should be the director.
Let me just clarify. We post openings and people are free to apply for those. We do not mandate turnover. We do not force people transfer after a short time.
Neither do you facilitate people staying in one facility.
Actually, in this economy and with the situation on relocation, there is more staying in position.
All right, let me just go on because the time is limited. I have a question, Ms. Barako, about these logs. You know, I mean, I fill out a log whenever I did colonoscopy at the VA, and I don't understand what information was missing from the log, because usually they're quite complete. So you said they were unreliable, but why were they unreliable?
Again, they were unreliable because it was incomplete information. It was
What information was incomplete?
names were not spelled correctly. There was not exact information on the.
So the people are not filling out their logs correctly? Is that what you're telling me on a routine basis?
Our official record is the electronic medical record.
But you already told us that method of doing it doesn't work very well, because you can't go back other than, you know, a paper log is permanent.
No, we did go back. Yeah.
Well, but you couldn't find the people that you were looking for on the electronic medical. Did the 79 names occur on the paper record?
We looked at it. Was in the
Were the
electronic
79
medical
names
record.
on the paper record? Yes or no?
Actually, from the logs, what we found was 12 individuals. The 79 were from the letter that the patient wrote.
So those 79 people were not in that paper log?
The 12 individuals were not in the record, in the electronic record.
But in the paper log, were those 79 people in that paper log book?
No, the 79 individuals came as a result of a letter that we received.
So they were not
back
in the
into
log
the
book, you're
electronic. No, right. We went back into the electronic medical record and found those 79.
Mr. Schoenhardt, I just wanted to express my problem with the electronic medical record as it exists, because obviously there is some sort of problem here where the people cannot go back easily and find out what the deal is, and that to me is really frustrating, as is the fact that the log did not contain 79 names. I don't understand what's going on here, but you know, this kind of stuff doesn't happen where I work, and I mean, I don't think it should be happening where you work.
Yes, sir. And I would just acknowledge, I think it's important for the committee to know that we have taken the Miami experience with the 79 and with the 12, and that has gone into, as part of the national AIB, there were a number of recommendations having to do with data collection and the rest. Part of the issue we learned in Miami is that the average medical center director, maybe in their career, will have one or two of these kinds of instances that is involved with putting a data group together and making sure we mine the data and get it right the first time. The AIB included a number of recommendations at the national level to ensure we bring experts to bear when we have an incident like this, to ensure we get all of the veterans that we can get to in the first place. But let me urge this. I think it's important for veteran safety that we be always in discovery, always looking, did we miss anybody? Always having our receptacles open to, is there anybody that we might have missed? Because first and foremost is our responsibility to every veteran to ensure, if we have any reason to believe they should be notified, that they are notified.
Well,
That's what we would continue to urge in our culture.
Well, to tell you the truth, I like to have this paper record, because then there's something actually written down, whereas, you know, like the electronic medical record, sometimes things disappear and then you can't really find them afterwards. So I like to have this written document, so I would encourage that to be a part of it, and I think a lot of time. Thanks.
Mr. Waltz?
Well, thank you, Mr. Chairman, and I want to say thank all of you for being here and your work you've done. I think we do all know this is a zero-sum proposition with our veterans, and I have said it, and I'll continue to say it. I am the staunchest supporter of the VA, and because of that, I'm the harshest critic, because the job is too important. I'd like to say, Mr. Schoenhardt, thank you as a naval officer for your service. I'd also like to get your perspective on this. Am I right that you were CEO of SSM Healthcare for 22 years?
No, I was the chief operating officer.
The chief operating officer.
Yes, sir.
Okay. What did they do?
Excuse me?
What did SSM Healthcare do?
Very much like VA, it's a multi-state but much smaller healthcare system. At the time I left, we were in 4 states, and it's a faith-based, Catholic-sponsored organization.
How did SSM report their medical errors?
They came through the report similar to what we have here in VA through issue brief, sentinel report.
Which is stricter in terms of every incident that happens, the private sector or the VA?
Well, I want to be careful to
The reason I ask this is no error is acceptable, but I want to be very clear on this, the requirements, that this is not, and I'm going to say this, and I appreciate you taking a macro position on this, because trying to lump them all together, I'm going to stand firmly with the three that I supervise in Minneapolis and in Toma and in Sioux Falls of what's happening and try and get at the systemic cause of where this is at. That's the reason I asked this.
let me say this. I do not want to cast aspersions on the private sector, but I can tell you, after the years I've spent in the private sector, our system is the most transparent, the most rigorous in VA, the most accountable for holding people accountable that I've seen.
Well, I can back you up. I represent the Mayo Clinic, and they would agree with you. And with that being said, that doesn't remove from where we're at trying to figure this out systemically. But I do think we need to note that if we're starting to make changes, I'm very, very hesitant here that if this is system-wide, we need to understand what happens, because I do not want the quality of care being reduced at VA Minneapolis because of an incident at Miami, or if that's the case, if that's clear. Just a couple things, I'll move on. Mr. Weaver, I do think my colleagues are right. I think you used an unfortunate choice of words with Miami. I think when one thing you said is that Miami VA had challenges. No, the veterans there had challenges. You had some problems that needed to be addressed. So I think you, and saying we're making progress and feel good about it, I agree. I think maybe again, and I'm not going to put words into your mouth, this is zero sum. If one veteran doesn't get the care they need, I'm sure you're not happy. I'll let you speak on that. I'll ask you though, Mr. Weaver, on this. How long have you served in the VA?
I have 32 years in.
Are all VA medical centers created equal?
No,
Okay. Is that important to keep in mind, in your opinion?
I think it is.
Okay. Ms. Baracol, I'm going to come to you on the specifics of running this, the endoscope issue. I'm with my colleagues' frustration on this one too, because in 2009 I said in that hearing, and some of these folks were there too, and we went through this trying to understand what happened, trying to be transparent, trying to make, as my colleague said, someone accountable for this, but more importantly, making sure that it never happened again. I had all of these folks, and you're right, there were 11 different contractors that provided these, I believe. I had the folks come in and actually assemble and had me reassemble in my office an endoscope. We know the problem was a two-way valve amongst one of the contractors, if I'm not mistaken. So what I ask on this is at that point in time, it became very clear to me, and we had a great commitment from our VA that new processes would go out, because I made the statement at that time is, my local Quick Trip convenience store has a little chart in the bathroom that shows who cleaned the damn toilet each hour. There was no such thing for the endoscope. So that being the case, did you adopt what others adopted that did not have a reoccurring problem? Did that happen?
We have, yes, we have, we haven't perhaps applied everything. I haven't seen all of the system, but from a system perspective, we did an after-action review as a system to understand what others were doing. I will tell you that I don't stop at the endoscopy issue alone. I take the OIG reports that come from every facility that in the system where they identify an issue, and I have trended the problems that have been found, and I issue that to my facility to ensure that those concerns are not concerns at the Miami VA. We have done consistent improvements, as I mentioned before. My nurse exec, who the sterile and processing section reports to, has gone above and beyond, and she has gotten certified herself in this certification, which is an international certification that on sterilization of instruments. In addition to that, the nurse that oversees that section, as well as the nurse educator for the sterile and processing sections, have received that certification as well, and they are certified nurses in instrument sterilization. Okay. As well, 80% and within the year, 100% of the individuals who we have hired in that area will have received the certification, which is something that was put by the, it's an international.
That's international. Mr. Schoenhardt, again, I don't want to put you in a position to be speaking for the private sector. You just have the most experience here, is one of the reasons I'm asking. You've got a foot in both camps. If there would have been a problem with an endoscope at a private hospital and I was due for my colonoscopy, would there be a place I could find that easily to know that hospital had a problem?
I don't think as transparent as we have in the VA. And I would tell you, sir, we lead the industry, and we're working with FDA in this very area. We're making contributions not only to veterans care, but care to all Americans in this work.
Okay. Well, I do want to make it clear that I'm with my colleagues here on this accountability. I'm with making sure that there's a sense of that we're getting better, but I also understand, and I'd leave it with this. I think, Mr. Schoenhardt, you said I'm a systems analysis guy too by graduate training, but I also know I do believe in systems, but I understand that you're only as good as the people who are there, and I think we need to keep that in case. And this might come back, and I certainly don't want to speak for my colleagues, that if there's people there that can't do it, they need to move.
Let me just assure you, Congressman, we will always put in place leadership that's in the best interest of our veterans.
Well, I thank you all, and thank you for coming today to help us understand this. I yield back, and thank you for the extra time, Mr. Chairman.
Yes, sir. Mr. Huelskamp. Get your mic, bud.
Sorry for that, Mr. Chairman. I appreciate the time, opportunity to ask some questions. First question would be for Mr. Schoenhardt. What is the VA doing to promote transparency as well as providing protections for employees that would like to report misconduct?
Let me just again allude to what I mentioned in the opening statement, sir, regarding transparency. There is no other system that I'm aware of anywhere on our Aspire website that is putting out aspirational goals to improve care for our patients, and our performance to date in getting there, as we've seen under Secretary Shinseki's leadership in putting this kind of level of transparency forward. It is unprecedented. As it relates to ensuring that we have a safe culture where people can come forward, let me mention a couple things, and if I could yield to Mr. Weaver, who will talk about specifically what's being done in Vision 8, which we may adopt nationwide. First, we hold these all-employee surveys. We have a good high return on that going forward, and that is an indication of employees' comfort in going forward with psychological safety. We have what we call a program called CREW, which is civility, respect, and engagement. We take teams like the OR teams and those that are in highly critical functions, like an aircraft carrier flight deck crew might be, and build camaraderie and ability to treat people with respect there. We are undertaking throughout all of VHA leadership appraisal teams. Part of what has become apparent where we have breakdowns in terms of people going forward and acting on information that requires improvement is that front office, the top leadership of the medical center, we want to get good idea of how that team works together through a formal process, and we're undertaking that now because I'm convinced it starts at the head of an organization in terms of the health with which even that senior team is able to effectively communicate with each other.
And what happens when that fails? I mean, who is held accountable?
The medical center director is the captain of the ship, would be responsible for the culture of the hospital as well as the front office.
And system-wide, and I'm new to Congress, I'm a freshman, how many medical directors have been disciplined or disciplined in any way or removed for failures in their sphere of responsibility?
Sir, if I could take that question and bring it back, it would depend on the period of time that you're going back to. There have been a number of...
When was the last one removed or punished at that level?
Probably, I lose track of time, but I'm doing this off the top of my head, but it would be several months ago a director was removed. And I can get you the specifics on that. I just, I want to give you the accurate information.
And I appreciate that, and I appreciate the description of the model of how things would occur, but I have been in this position for about 9 months, and other folks and my colleagues have talked about troubling this incident. I would say I'm particularly angry of what's occurred. And I'm angry about things that have occurred in my district, complaints that have come to my attention, and the absolute failure of the VA to respond to those complaints. The inability of a member of Congress to get accurate information. It's just like pulling teeth. And I can't imagine if a victim of the situation and the family was trying to get that information that I can't even get. It's one thing after another. There is not transparency in this particular situation. It's a very troubling incident. And the idea that we can talk here about holding people accountable and responsible, but we can't even get accurate information. It certainly seems like an attempt to cover that up. I don't know how widespread it is. I know it's in just one particular incident. But I would say I'm very disappointed, and that's not the medical director's fault. It's the system. It's the folks at the top. It's your job. It's to hold them accountable. And if I can't get the information, what am I supposed to do? Just continue to ask after 6, 7, 8 months of trying to get information and having apparently a response from the VAs will give him enough to make him satisfied for 2 weeks, and then he'll call again, and then we'll give him just a little bit more. What am I supposed to do, Mr. Schoenhardt?
First, Secretary Shinseki has made it very clear that we are to be transparent and accountable. And we would like to follow up with you in ensuring that we understand the root of where you are having problems getting information. I insist that we get good information from the medical center to the VISN to me and to BACO and then for the rest of the leadership of VA. If we're having difficulty getting information to your satisfaction in a timely fashion, we need to work on that. I understand that sometimes it's the process of requests, and I don't mean to describe this generally, but I think there's probably an area where we could improve in terms of what information requests, because I think at times we're not clear what's being asked, and we probably could do a better job of clarifying that. In any case, we both own the problem, and certainly VA owns the problem of ensuring if it's not clear what's being requested that we get timely clarification, that we do the timely review and the release, because we honor and respect this committee's responsibility for oversight.
And I don't know as far as who owns the problem. All I know is there's a deceased veteran and some possibilities of failure of the system. And again, I don't want to start digging in there and find out it's a much broader situation than one particular individual. But I appreciate your willingness to help. But I'll just say that it hasn't happened. It's no excuse. We're going to help you sometime in the future. And but this complaint is and complaints related to that are again make me very angry. So we should call you directly if we want that information.
Yes, we work with our OCLA staff, our Office of Congressional Legislative Affairs, but I can assure you we will work together with you. I'd like to have us follow up with your office offline if
Absolutely, and I appreciate later today or first thing tomorrow morning that you call my office and we'll get started and maybe we can get over a few levels of bureaucracy. So, sir, thank you. Sorry for taking too much time, Mr. Chairman.
Thank you very much. Ms. Barracall, let's go back to the veteran that escaped your facility. A root cause analysis has been done.
Has been completed.
How long did it take you to approve that root cause analysis?
We have a 45-day window to complete these root cause analysis. We initiated the root cause analysis quickly. I don't have the exact information, on hand, but I'm happy to get it for you. We invited people from the network.
How long did it take for you to approve the RCA?
As soon as the formal RCA was presented to me, I signed it.
Okay, let's all go back to my opening statement about being open, honest, transparent. Did you alter the text Did you do anything to the root cause analysis that was presented to you prior to signing it?
What happens in the root cause analysis is that I did not alter the text.
You
What hap-
changed nothing in the root cause analysis.
Not to my knowledge. No. What happens in the root cause analysis is the team comes and presents, and questions they present to the whole executive leadership team. And at that time, we do ask for questions, we ask clarification, and then the written document and recommendations are presented to me, and I sign them.
And here's why I'm having a little bit of a problem, because we've asked Ledge Affairs to provide us every AIB and every root cause analysis from '08.
Mm-hmm.
I think there have been 14 AIBs done. We've gotten 3. We haven't gotten any root cause analysis. None.
At the facility level, we have submitted everything that has been requested of us. And there is a vetting process.
Well, since we're here in an open discussion, were there any management issues raised in the root cause analysis of the veteran that escaped your facility, walked out, shot a police officer, and was killed?
I'd like to recollect exactly all the recommendations.
If it was pointed at you, you would probably know it, wouldn't you?
Yes.
Was there anything in the root cause analysis that pointed at leadership at your facility?
I honestly, I'm trying to be honest because that's what you've asked me to do, and I am honestly not recalling a specific recommendation.
I'm asking you now to provide that root cause analysis to this committee. Can you do that?
Yes, sir.
When?
As soon as I get back to Miami.
Can they transmit it before you get back to Miami?
I will, yes,
Thank
I will get that to you.
What happens if a veteran presents at the facility with congestive heart failure?
They are, I rely on my clinicians to take care of the patients, and if they present to the ER, they are taken care of in the ER.
And for what reasons would a patient not be admitted if they had congestive heart failure?
I'm not a clinician, and I would have to defer to my clinicians in making those decisions. On a daily basis, I must rely on my clinicians to make clinical decisions. Day in and day out, our doctors are making decisions on our patients, and I cannot possibly replace their judgment with mine.
So would you know if a veteran had come to your facility, presented with a particular disease, returned home, and then expired the next day? Would you have any way of knowing that?
Usually what happens is any deaths we do review, and there is, where indicated, we do peer reviews. Where the death is not expected, there are peer reviews that are done. We review to see what happens.
There is a way that you would know if a veteran presented 24 hours prior to their death at your facility, but was sent home. You would have a way of tracking that?
Every morning we get a report on anything that is unusual that might have happened on the evening before or the day before. We get a report every single morning. I meet with my leadership. The staff in the ER presents their information. Following that, we stay with the leadership and discuss anything that we might need to follow up on.
Is it unusual that a veteran would come to your facility, be not discharged, but just be sent home, not admitted, and would pass away the next day? Would you consider that unusual? And if you do consider that unusual, is that something that you would report then to the VISN that this has occurred?
We would normally report deaths, unexpected deaths to the network, yes.
So this particular, if an instance like this did occur, it would have been reported to the VISN?
It would be my expectation that it would be reported. If it's an unexpected death, there are reports that go forward.
Regardless.
No, we don't independently, like in an issue brief or something, report every single death if it's an unexpected
Regardless of
death.
what the peer review may have found, you would still report it.
The peer reviews focus specifically on the provider to determine whether it was a something that didn't go the way it should go in that direction. So, yes.
If a vet, okay, let's go inside the facility. Now we have somebody who has been admitted to the facility and is having surgery. If there is a death on the operating table, what would prevent that death from being reported to VISN?
Those would be reported to the network.
All deaths on an operating table are reported.
Are reported. Should be reported. There's a system that we put through to report unexpected deaths.
All deaths on the operating table are reported to the VISN.
Yes, sir.
All deaths.
Unexpected deaths
There's a
are
difference
reported.
now. Unexpected deaths or deaths. If a patient dies on the operating table, is that reported regardless? Is that reported to the VISN? And if not, why not?
It would be my expectation that it would be reported.
Is there a root cause analysis on every death on an operating table?
There would be a root cause analysis. Again, if it's an unexpected death, there would be a root cause analysis. And
what would be an expected death on an operating table? I would expect, if I went in for surgery, you wouldn't expect me to die. You'd expect me to recover. Now, what is an expected or an unexpected death? What is that?
Again, it's, I'm not a clinician.
You're the director of the medical center.
Correct. Not a clinician.
For now.
I am not a clinician, but I would expect that any unexpected death would be something where, if they found something that they were not expecting to find. I believe that any death would be
reported. Who makes the determination as to whether it's expected or unexpected?
There are systems in place to report, and we've had a variety of groups come and look and determine, that we have done things appropriately. All deaths are reported, and they're investigated, but not necessarily through the RCA process. We do investigate, again, we do peer reviews to determine.
Is a peer review punitive?
It could lead to be, but not necessarily a peer review. There's a group of peers that review to see whether or not the care that was provided was adequate care.
So if everybody just decides that the care was adequate and that it was an expected death, you may not even report that to the VISN.
Then there's a committee that reviews after, there's the peer review, that it goes to a committee to review, and then a determination is made. There are rankings or scores that are provided determining whether or not it's a.
Who makes the final determination as to whether or not it is sent to VISN?
They are reported to the VISN. The deaths are reported to the VISN.
All of them?
No.
Is there ever a death that's not reported to the VISN?
Um, uh, we have, for example, deaths in hospice. These would be expected, you know.
I'm talking about on the operating table.
I would expect.
I'll let you think on that, Mr. Johnson.
Thank you, Mr. Chairman. Mr. Schoenhard, you and I talked before the hearing started. We're both veterans. You know, and from your experience in the private sector, I agree that, you know, there's some good to be found anywhere. But I think based upon our mutual experience with the culture that we had, where these veterans come from, as a squadron commander, if my morale factors were going down like VAMC's in Miami is, if my customer service statistics were going south like theirs are, I can assure you I know what accountability would mean in that case. I'm just curious, are you astutely hearing the responses to the questions that this committee is asking and some of the answers that we're getting? Because you've made a statement that you're prepared to hold leadership accountable, and I believe you. I'm anxious to see the results of that. That's a statement. Let me ask you a question. Last month, the Miami Herald reported that an administrative investigating board conducted by the VISN that they had obtained through a FOIA recommended disciplinary action for both Dr. Vera and Ms. Baracal at the Miami VAMC. When asked for comment on whether these actions had taken place, the VA had none. In documents submitted to us just last night by the VA, only a draft, unsigned, and undated recommendation for action was provided. And then 30 minutes before today's hearing, a notice of admonishment was provided that was dated in December of 2010 with no specific day. Can you clarify and explain this discrepancy and how that fits into your, we're going to hold leadership accountable? Yeah.
Yes, sir. The AIB recommended administrative action. The one that I convened, the National AIB, after the second disclosure of the veteran who had not been contacted, and found that there was reason to take administrative action against the medical center director and the chief of staff. The way that works in VA then is that I shared that report with Mr. Weaver, and he took the administrative action. He may want to speak to the process we use in VA and in government.
What administrative action was taken?
An admonishment was issued against both individuals.
A veteran escapes the facility.
No, sir.
And dies.
That was taken, this was predating this incident.
Okay. All right,
so
this admonishment that came through the Miami Herald incident from a previous AIB, correct? Have I got this right?
That's correct.
Then the patient that escaped the center and subsequently committed suicide happened after that, correct?
That's correct, sir.
All right. So do you think the admonishment worked?
I think
Next question. Can you provide to this committee, Mr. Schoenhard or Mr. Weaver, a record of disciplinary actions from the Miami VAMC over the last 24 months? I would specifically like to see, and with the chairman's approval, I would like to see the incident. You don't have to give us names for privacy. I would like to see the incident and the action and what level of leadership and management that action was taken against. Ms. Baracal, last week, one of your employees was arrested for selling names of veterans. In the past 6 years, it's estimated that more than 3,000 veterans' information has been sold. Have you alerted any veterans that their information may have been compromised? And if so, how have you done that?
Actually, this was an investigation that was done by the IG, and it was a covert operation. I learned about it at the time, shortly before they were going to be arresting the individual. And at the time, what we knew was that there was information on 18 individuals that was compromised, and then on...
Have those veterans been notified? Yes or no? Have those veterans been notified? You talked earlier about a process for making sure that veterans are notified. I've heard that from various pieces of testimony this morning.
We are in the process of notifying the individual.
So they have not been notified. When was the guy arrested?
This just happened in the last...
And you didn't know anything about the investigation prior to his arrest?
I knew that they were doing an investigation and they had some concerns. The individual...
So prudent leadership would be poised and ready to act if the investigation proved out, right? That you would then immediately begin to notify those veterans whose information had been compromised. And you're saying that as of today, there still have been no veterans notified? You're only in the process of? 18 veterans, how long does that take? I can make 18 phone calls in 30 minutes.
We have worked with our privacy officer to make sure that the information is done and that we communicate to those veterans as we need to.
Okay, and have they been communicated with?
I believe so.
You believe so?
Yes, sir.
But you're not certain?
The 18 have been communicated. The individual indicated...
A few minutes ago, you told me that you were in the process of notifying them. Now you're saying that they have been notified?
We have communicated with the privacy officer whose responsibility is to communicate.
I'm not asking if you communicated with the privacy officer. Have the veterans whose information been compromised been notified that their information has been compromised and sold by an employee under your direction?
I will have to get that information for you.
Okay, so now you don't know. First it was you got a process, then they have been notified, and now you don't know. Mr. Schoenhardt, if I'm the wing commander, I'm paying real close attention to these answers. Mr. Chairman, I yield back.
I can answer the question for you. According to AIG last night, they have not been contacted. Mr. McNerney.
Thank you, Mr. Chairman. Mr. Schoenhardt, I thought it was an interesting that you had assessment. Your assessment was that the transparency at the VA hospitals is superior to the transparency in the private sector. And I actually do believe that. But in this particular case, is the problem we're seeing in Miami, is that a transparency issue, or is something else going on that's causing this set of problems, or what's going on here? I don't understand why this facility is having so many problems.
Well, sir, we have, I think, a culture which is in the process of improving, and I saw the chairman's bar graphs earlier in terms of the results, but what we are doing is holding people more accountable over time than has been done in the past. And that's what we expect a medical center director to do. And there will be issues and concerns that arise.
So in prior years, people weren't being held accountable in prior times. Ms. Barocal?
They were, sir. I want to be careful with the impression left there. But there is now increased sense of accountability, and the thing which I would also say that is beneficial here is that we have the support of our union partners and our veteran service organizations in making this change under Ms. Baracal's leadership.
Ms. Baracal, what's your assessment of why there are so many problems in Miami?
Miami, I think, in part had, when I arrived, Miami had a number of critical vacancies, including the nurse exec who had been selected for a previous position, the associate director who oversees the administrative part of the operation who left shortly after I arrived. There were at least 10 vacancies at the time from senior leadership positions that would set the tone and lead the organization. I have had, at this point, and there
Have these
have
been filled now?
Sir? Yeah.
These vacancies been filled?
I have spent whatever time I haven't been dealing with these kinds of situations, I have spent trying to recruit a really incredible team of competent people to see this organization through this.
The thing is that in 2009 we had this this institution in front of us because of the endoscopy issues. So, and I take it, Mr. Schoenhardt's statement that it takes time to turn around, but 2 years it's a fair amount of time. I mean, you can do a lot in 2 years.
I'm sorry.
So why are we seeing you again here in 2 years? I don't understand why more hasn't happened in this one institution.
I believe that we again had I have spent these 2 years, the initial year assessing the organization and preparing the organization to face the challenges that we have with our veterans and the ones coming up. I've had the opportunity to review the strengths and the weaknesses of the staff, and to not only fill the positions that were vacant, and that includes many of the service chief senior leadership positions. Have done almost a complete turnaround there, and in addition to that, I have moved positions, individuals from previous positions to positions where their skills are enhanced.
So are these positions hard to fill? Are people not wanting these positions?
Some of these positions are hard to fill. Miami has gone through, in the last 3.5 years, through a tremendous amount of scrutiny, and unfortunately, when these situations happen, it takes a toll on the organization. It is difficult to recruit people to come to an institution that has this amount of oversight.
Well, let's talk about cost overruns for a little while. How does a facility run a $30 million deficit? I mean, what does that mean? Does the money come from other facilities? Are other facilities being hurt because the Miami facility is running a deficit? The bills not go paid? I mean, how do you do that? How does that operate?
Sir, what happens at the just to talk about a little bit about the budget process at the national level, they allocate X dollars for each network, and then the network through a collaborative effort partnership with the directors make a determination of what the budget should be for each medical center based on the unique number of patients that are there, the complexity of the patients, etc. During this past year, well, first of all, the network holds a small amount of money in reserve for emergency situations like hurricanes, wildfires, etc. And we also hold some funds in reserve that the medical centers have agreed to have for high-tech, high-cost, and some other kinds of things. So as Miami moved forward, and we have other medical centers in the same situation, this past year they had some financial challenges that were not anticipated, and they were also making some changes within their organization, which creates when you bring in trying to meet the priorities of the agency. We had to add some staff, and when you do that, sometimes there's some overruns because you're waiting for people either to transition out or or we have to move them from one program to another. So within that, those dynamics, we were faced, and Miami specifically was faced with a deficit, and the network worked with them to meet their needs. And I go back to one of my earlier statements, is that our focus is on quality of care. That cannot be compromised. We look at satisfaction and cost effectiveness. So this past year, we were able to work with Miami, and they ended the year with a balanced budget.
All right, I'm going to have to yield back.
Ms. Barracall, since we're, I was going to go another line of questions, but since we're talking about budgets and funding, is it correct that, I think it may have recently been filled, but is it correct that the public affairs position at your facility was vacant for 2 years, and during that time, basically it was filled by rotating service chiefs to fill those duties?
The specific public affairs position at Miami has been vacant for quite some time. And during that period of time, I had established a communications and protocols section. The chief of that section has responsibility for the media section, for the public affairs area, and for the outreach section of the medical center.
But there is a vacant public affairs position today.
No, there is not a vacant position today.
There was 2 years up till now. I mean, there was an open position for 2 years.
Approximately, that is correct.
Where does the salary money for a position like that go when that position is unfilled?
It goes into operations, into what we might need to run the medical center. Our medical center, as I indicated before, has increased the number of veterans that we have seen more, almost double the national average. So we are seeing a lot more patients. In addition to that, we are a referral facility, as Mr. Weaver had indicated, for several of the other facilities within our network. So we receive patients from the other facilities in the medical and the network to be able to address their needs, and that also it impacts on our budget. In addition to that, fewer veterans have insurance right now, and so it impacts our ability to collect from insurance, also to supplement our budget, which is also something we utilize. So those. In addition to that, during this current year, we have finalized a very robust budget briefing where each department received what money they would get, and they were asked to review their programs to let us know how they were going to be accomplishing the work that needed to be done. The budget briefings brought in every single one of the service chiefs to provide information as to how we were going to meet the budget moving forward, including efficiencies that we could create, such as merging different departments under one leadership, working with other facilities to collaborate on workload, redesigning positions.
Mr. Weaver, how many facilities within VISN 8 ran a deficit this year?
We had approximately 5 out of our 7. For different
5
reasons.
ran a deficit out of 7.
Right.
Who was the highest?
The highest. I'm not gonna. I don't recall the highest. I don't remember if it was Tampa or. I don't recall, sir.
Okay. Would you report back to us who had?
I will. I'll give you the deficits for each of the facilities. In fact, I can probably get it now, but if you don't have it. How short was Miami? You said that number, I think, already.
What kind of deficit did they run?
Have them here, sir. Miami at the end was 19.7 million, and our highest was Tampa at $28.4 million.
Did you approve the $2.5 million executive suite renovation at Miami?
I'm sorry.
Did you approve the $2.5 million executive suite renovation in Miami?
That would have, I think that would have come through my office.
It would have?
I think I better get back with you on that. I want to be 100% sure that I'm clear on that.
Ms. Baracall, did you suspend golf cart service for the veterans?
Did I suspend what, sir?
I'm sorry. Did you suspend golf cart service for the veterans in the parking lot?
We did in the parking lot. We did suspend that service. We what we did was
That's
when
all.
at
I
the
just
Fisher
wanna know
House.
if you did. Now, how do you determine that the current office renovation of approximately $1 million to your executive suite wasn't sufficient, and that $2.5 million renovation was more important than golf cart escorts for the veterans trying to come into your facility?
Sir, I would have to get back to you on that.
Well, what's more important, your office or golf carts for the veterans to get to the hospital?
I would always put the veteran first, sir.
But you canceled the golf cart.
The golf cart issue was canceled during this year. I would have to look at the information that you are giving me about the renovations. But
Have you renovated your office?
But my office is not renovated.
Are you going to be renovating your offices?
What we've done with the office was we painted the paint. I would have to look at the information that you have on hand.
Are you going to be renovating your offices?
No, sir.
Okay. So if I produced a contract executed that said you were, would you change your answer?
I really would need to see what we are.
We'll produce it for you. We'll bring it. We'll show it to you. You've contracted for that to be done. And I just think it's egregious that you would stop golf carts from escorting veterans to the front door, but you would sign a contract, or somebody would sign a contract to expand the executive offices. Doesn't that sound odd?
Yes, sir.
Dr. Rowe, welcome back. Took a Codell to Afghanistan over the weekend. Thank you very much. You and Mr. Waltz, I know, went along with some other members. Thank you for making that trip. You're recognized if you have some questions.
Thank you, Chairman, for recognizing me. And yes, it was a great, Mr. Waltz and I had along with other members of the Veterans Affairs Committee, had a great visit with our troops in Afghanistan. One of the problems I have as a healthcare provider, when you look at some of the issues here, is Ms. Baracall, how would you, because I've had to do this my entire life, is how would you be able to sit down with a family of a patient that has had a mistake made, an error, and the way these scopes were cleaned, and sit down and talk to them? That would be one thing. But how would you sit down and talk to the 79 who didn't get notified and 12 others that were picked up by somebody else? How would you look them in the eye and say, would you say, I'm sorry? Or would you look to have procedures that could never happen again? Because that was whether the virus was transmitted or not is irrelevant. The fact is these people weren't notified that something could have happened to them. And I've had to be the one that would sit down and say, hey, I didn't get this lab test. Can you sit down eyeball to eyeball with that patient across the table from you and give them a correct answer about why that didn't happen, why maybe their life was put at risk?
I have always strived to be very patient-centered, and precisely the reason why those patients were identified.
Did you talk to any of them personally?
Sir?
Did you talk to any of them personally? Did you sit down yourself as basically the CEO responsible for patient care at that hospital and say, this happened?
What I did was I submitted an apology in the original letter of notification that was heartfelt. And in addition to that, I have my clinicians meet with them so that if there were any follow-up questions they had in terms of the
How do you explain that happened? I mean, when there were so many that fell through the cracks. How did, in other words, how did that big a mistake happen?
There was, as the AIB points out, there were a series of areas that had problems for years, and this AIB identified them, and I proceeded to address those issues.
So there are no issues like that now?
I don't have those issues right now. Now, I'd like to point out that the additional members that were identified because Miami did the right thing to, I personally did the right thing to report that there was a problem and that we should continue to look further. And my commitment to this committee and to anyone who will listen is that I will continue to look.
Well, we've had, I know you mentioned that Mr. Weaver mentioned that 5 of the 7 VISNs were in a deficit, and I certainly understand from talking to my own VA at home in the VISN why that's insurance. You're correct, is they're collecting less private insurance dollars, and I understand that. But to go with the chairman's questions a moment ago, if I were having problems buying food, which is pretty basic, I wouldn't go remodel the inside of my house. And the question is, if we're not providing basic health care needs for our veterans, are we fixing up my office so it looks nice?
I would like...
I'm going to ask Mr. Weaver that. Is that being done? I know you didn't answer the question the chairman asked a minute ago. Maybe you couldn't, and that's fine if you can't.
Yeah, I think I misunderstood what he said. I thought he was saying emergency room, and I was thinking about the trailers outside of the facility, so it was my apology. I just misunderstood that. As far as executive offices, no, I think we have to take a look at what this contract has, and if that's indeed what it is, then we need to take a look to see.
I mean, I guess the question I'm asking again, if you can't buy food in your house, that's pretty basic.
Right.
Would you be remodeling the bedroom?
No.
No.
You're absolutely right, sir.
You wouldn't. You'd be spending that money on veterans, on their health care. The men and women that I went out to a forward operating base with Sergeant Major Walsh and shook their hands and looked at them in the eye. That's who ultimately will be your client, your patient in the VA system. One other question, and they may not have this answer, Mr. Chairman, but because of this problem in Miami, there have been numerous settlements in the legal system, and it's not clear to me in the briefing we have here how much that's been, how much money have the taxpayers spent because of this error. And I certainly know in the private sector where I came from what would happen in that case, who would pay that money. But how much money has been paid out? And so far, it's not clear to me. It looks like it's in the millions, but I'd like to know that number if anybody has it.
I did not submit that information, but I know we would have that information. We can get that from General Counsel.
Okay, but I'd like to have that so the committee would know through this error that was made how much the taxpayers were on the hook for, plus the fact that the risk that the patients had. I yield back my time, Mr. Chairman. Thank you.
Mr. Walls.
Well, thank you, Mr. Chairman. And again, as I said, this is zero-sum proposition we're at, and I certainly take no pleasure. And I can assure all of you that it's not through collaboration that this hearing is taking a pretty direct turn in a very frustrating and quite honestly a very troubling manner for me. I'll defend anyone's right on due process to the end of days, but I want to be very clear, and I have to I have to say, Mr. Schoenhardt, Mr. Johnson might have given you some good advice to listen to the wing commander. I'm going to speak now as the senior NCO and some recommendations, and I'm going to ask a couple things. Just some troubling decision-making that I have. Did we have a contract to replace locks on the doors?
We currently have a contract to replace locks.
What happened? Why did we do it twice for $24,000?
Sir?
Why did we have to do it twice for $24,000?
The most recent contract has to do with the keys being lost.
Who lost them?
I was personally responsible for that. I don't recall the details of why I had. There was something happening at the medical center that evening, and I took the keys out of the lock where I keep the keys in my office. They were in a single ring, unidentified by anything else. I am currently raising a 9-year-old grandson, and after addressing whatever it was that I had to pull the keys out for, I was running late to pick him up at school. So rather than going to my office and locking the keys again and leaving, I left from the location and had the keys in my purse.
I would say, and I don't want to cut you off, Ms. Bird.
My car was broken into.
I'm certainly empathetic, but it comes down to that accountability piece again in a very strong way. And next thing is we've got police officer shortages, but are we paying police officers overtime to escort employees to their car?
We are paying police officers overtime. We have a remote parking lot because we had to engage in that process because we had the Fisher House as well as the mobile ORs that took away most of our parking, much of our parking space.
This was the best contract we could get. So we signed a contract for parking. It's in a bad neighborhood. We're paying $13,000 in overtime to escort employees while we're shorting officers that are there in case of, and we know that VA hospitals can have problems with folks coming in and need to have that there. Could that contract have been better written?
We do have a contracting section that does take care of the contracting options, and we did listen to concerns from the employees about, the parking area. So we did go and check, and it was, there had not been, it was a safe area. I will tell you that the medical center has received approval to purchase a piece of land to bring the parking closer to the medical center.
Yeah. Well, my morale is low, and I don't work at Miami from the things I've heard. Again, perceived reality can be reality many times, Mr. Schoenhardt, and I'm going to leave. There's a few things on people were removed, reinstated, and that. I appreciate the candidness here. I will say that. I certainly appreciate your devotion, and I know this doesn't come from a desire to not provide for veterans at all. But at the end of the day, outcomes, effectiveness have to be measures that we live by. And I have to tell you, I have been in numerous VA facilities, and this is not the norm. It is certainly not there. And so, again, I'm very respectful of the due process, and this was not meant to be, I can tell you I was hoping it wouldn't go in this direction, but it's very obvious to me that the facts stand pretty strongly. So, Mr. Chairman, I'll yield back to your side for some follow-up.
Mr. Amade, do you have any questions? Mr. Johnson?
Thank you, Mr. Chairman. Mr. Schoenhardt, you in your last few comments, you talked about how you didn't want the wrong perception to be left here. You talked about how you thought when asked what the problems were, what was the root cause of so many problems in Miami, you talked about the cultural problems and the fact that you thought the culture was improving. Ms. Barakal has been there for 4 years. How much time do you give to see cultural improvement? I have a follow-on question, so please answer that one quickly.
Sir, let me just again emphasize, and I appreciate the opportunity to respond. We will put in leadership that which is in the best interest of our veterans.
Great, great. I'm glad you're going to do that. So then let me ask you a question. You were the COO of what company again?
SSM Healthcare.
Okay, how many locations, how many operating locations? I'm not familiar with them, but how many operating
Yes.
locations did you have?
We had about 20 hospitals.
Okay, all right. Did you know when you went into your staff meetings with your CEO, I sat on the executive level of a company as well.
Mm-hmm.
When you went into the meetings with your CEO, did you know the operating parameters, financially and otherwise, of those 20 locations?
Yes, sir.
And you could speak to those details in that meeting, correct?
Yes, sir.
And yet you've got a VISN director here who has 7 and couldn't answer the chairman's question about which one had the highest deficit. Does that seem odd to you?
Well, sir,
In that same line of questioning, the chairman asked repeatedly about a contract to renovate the executive office suite, and somehow Mr. Weaver heard emergency room trailers. You know, I'm not sure what's going on here, but I really hope that you're sincere about your comments about wanting to establish leadership accountability.
may I
Got a few more
respond?
questions. Yeah, please.
Thank you. Let me just emphasize again that leadership shapes the culture of any organization. You and I.
Starts at the top. You and I both know that.
That's correct, sir.
But
And
what changes have been made at the top since you got there, since these problems came to your attention? What changes at the top, and how have you established accountability with Mr. Weaver and Mrs. Barracow?
and we will continue to monitor all of what's going on. I can assure you.
Not monitor. Monitoring doesn't establish accountability.
By monitoring.
Are you denying any of these facts that are coming out?
No, but I will say this. We will make judgments regarding what is in the best interest of our veterans in service.
Well, I'm going to have to
Mr.
disagree that you're making those judgments up until now. I'm going to trust that you're going to make those because you've told this committee that that's what you stand for.
Yes, sir.
I'm going to hold you to your word. Those judgments have not been made thus far. That's what concerns me.
But could I...
Mr. Weaver, based on our investigation, it appears that staff directly connected to the Miami VAMC director identified employees to be interviewed by the VISN during the Administrative Investigative Board, and that the VISN used those names for their interviews. Now, I'm not a rocket scientist, but to me this seems like a conflict of interest, given that Miami leadership, if the people being interviewed about leadership works directly in the leadership team, they can influence the investigation. Why would VISN seek such input from the people that are under investigation?
Which AIB was that?
I don't have a number right here in front of me. Leadership. The Leadership Administrative Investigative Board.
Okay, that would have been on the third one, the anonymous letter. The individuals who would have been interviewed would have been anyone who would have been cited in the letter, and then also we would ask the leadership to look at the letter and see if there was anything that we needed to include. Plus, the chairman of the AIB had latitude to choose who he or his team wanted to interview. And his team was composed of people outside of the network. They were not members of Miami or VISN 8.
Well, Mr. Chairman, I think I'm going to yield back any remaining time, and I'm just going to summarize by saying this. You know, I'm sort of at a loss for words with what I've heard here today and what I have read in the documents that have been provided to this committee thus far. Mr. Schoenhardt, I don't envy your position, because I think you've got some tough decisions to make, sir, if you're going to stand firm on your commitment to establish leadership accountability.
Sir, I assure you and members of the committee and all veterans, we will provide the leadership that's in the best interest of our veterans. I just want to say also, we have in Mr. Weaver and Ms. Baracall, two dedicated public servants who have given their lives to this mission. This is the most mission-driven organization I've ever been part of. We have executives like Mr. Weaver and Ms. Baracall who have option to go to the private sector. They could make more money than they do, but they care about this mission.
You know something? I'd recommend that you let them go.
Well,
That would
sir,
be my recommendation. I yield back, Mr. Chairman.
Apologize. I was just given some numbers, and this came from VA, and I don't know where the conflict is, and we'll try to research and see if the numbers that VA provided us are incorrect. But it says 5 medical centers in Visit 8 received additional funds at the end of FY11. Those stations and the amounts they received are as follows, and the number one was Miami at $29.7 million. Now, you said it was only $19 million. Where's the discrepancy?
The information I have is information was prepared for me by my fiscal officer, and we'll see if there's some kind of correction that's needed.
Okay. Ms. Baracall, how many acting chiefs are there for physical medicine and rehabilitation services?
Right now, there would be one acting chief.
Okay, I have a letter that you signed on September 1st of 2011, which would have been a month ago. Effective August 1st until further notice, 2 physicians are designated as acting chiefs. Why would that be? And how are they being compensated? And is this the same job?
There would be one individual serving at a time as the acting chief. If there were 2 individuals, it would be
This says
as a
instructions, effective August 1st until further notice, doctor and doctor are designated as acting chiefs, physical medicine and rehabilitative service at the Miami VA healthcare system. Signed, Mary D. Baracall.
As a general rule, we would have one individual serve at a time, being the leader of the section. In terms of their compensation, at this time, no additional compensation has been received, to my knowledge. What we have done in the past is, as individuals had served
So wait, so they're both being compensated as physicians,
as physicians,
but not as
acting,
as the chief.
correct.
Okay, where does that money go?
Sir?
Where does the chief's salary go then? If nobody's being paid that salary, where is it going?
Any money that is a result of vacancies would go back into operation.
Okay, let me see if I can jog your memory just a little bit about the executive office and relocation from the 2nd floor to the 12th floor, A and B. Were you aware that you were moving from the 2nd to the 12th?
Oh, okay. Now I know what you're talking about. Yes. What we are doing, thank you for the clarification. What we are doing is Miami has had tremendous space issues because we are kind of like locked down by space.
And let me also, I understand you're locked down by space, but I understand this renovation is going to take patient rooms in order to accomplish. Is that correct?
Well, what we're doing is actually we have a master space plan.
Is it going to take patient rooms?
What we're doing is shifting it. We're going to be trying to do the patient care services in the lower floors and consolidate so that we can gain some efficiencies. Right now, we have individuals from different departments that are in different areas. So what I set up for that was a 3-tier program to review at the space needs of Miami. One of the issues was we had somebody from central office come and do a assessment of the physical plan to see, moving into the future, what the needs were going to be. And with that, determine, for example, how much square footage we would need for different areas. Separate from that, then I had a clinical group that is looking at patient flow to determine, once we have that piece
But I'm looking specifically, so you're not expanding the size of your executive offices by your move. Okay, they're going to be the same size or less.
Sir, that is what I would anticipate, yes.
Okay.
The intent is to create more space.
But when I asked you the question about a $2.5 million renovation, why would you not have known? I mean, if your whole offices are being moved, 10 floors?
This is a very long-term plan that we have in place
This
for
is
the
actually
whole.
a contract, and by the way, I have a service that tracks government contracts, so we have the ability to see all of this information, and the notice was on June 13th of 2011.
I believe that the idea of moving the executive office onto the 12th floor has been in the plans for quite some time. The idea was to be able to move the administrative functions to the higher floors and allow all the patient care functions to happen in the lower floors, so that we can become more efficient and more patient-centered. We have also done, as I said, had a clinical group look to make sure that our space is fully utilized in the way that is patient-centered, and that we do not have the patients going from one place to another to try to receive their care in a way that doesn't make any sense. So we're improving patient flow.
Thank you. That's your explanation, and I appreciate you being so candid with your explanation. Mr. Weaver, our bonuses for directors is one of the facets of bonuses for a director tied to patient safety reports.
We take everything, when we do a recommendation for a bonus, we look at the performance measures and then any other information that would be relevant. So, and then the recommendations go to central office.
But are patient safety reports one of those facets?
That would be a factor.
Did Ms. Baracall receive a bonus in fiscal year 2011?
No, she did not.
Did she receive one in 2010?
No, she did not.
You're absolutely correct.
No bonus.
You're sure?
Yes, but retention, now she has retention, that's not a
got
bonus.
retention money.
Right.
Okay. And we need to keep Ms. Baracall.
Well, my position is that in 2009, or she came in 2008, but 2009, we had obviously some significant problems. We have been...
you obviously still have significant problems.
Well, what are... yes, sir.
How much has she received in retention money?
10%.
Both years?
Correct.
So roughly 25,000?
Probably about, I think it's
Baracall, would you...
$18,000 about, and so it would be...
Per year?
Per year.
Okay, so we're talking 36.
Correct.
Okay. Ms. Baracall, does the facility have all the supplies it needs to properly care for veterans?
I believe at this point we do. We have looked at all of our equipment, and I have requested information from the different departments to ensure that we have adequate supplies
So
and equipment.
all of your labs or services are okay? They're not having any difficulty in getting any needed pharmaceutical supplies?
Some of the things that we are receiving should be, it's a process that goes on the whole year. So some of the things that they identify that they need, they submit them to us. We review through a committee, and then we allocate the money appropriately to ensure that we have the equipment.
Are you aware of any service or lab having to cancel a service because of lack of the necessary items to perform that service?
I am not aware of a specific instance unless...
Are you aware of any instance?
Where we have canceled services for lack of...
You didn't have the supplies to perform whatever the job was. It may be you're just not aware. Could that be? I would hope that you would, but maybe you just not.
The service we have in place is that when services have a need that has not been met, they submit those requests through the equipment committee, and then it makes it to our level to make decisions. So anything that the services have requested would have been reviewed with the appropriate data and with the clinical input to determine whether or not that was something we needed to get at the time.
Are you aware of any equipment deficiencies or malfunctions that have impacted patient safety at your facility?
Again, whenever there are, equipment needs or equipment malfunctions or anything that needs repairs or anything of that nature, I depend on the services to provide that information up through the process we have in place so that we are made aware and we can allocate the money to address the issues.
Mr. Johnson.
Thank you, Mr. Chairman. The last line of questioning highlighted a couple more questions for me. Mr. Schoenhardt, it's been established here that the results of the AIB investigations recommended disciplinary action. You've confirmed that admonishment has been the result. Does it seem odd to you that a retention bonus would be paid to someone that's not meeting their performance standards?
Sir, we take into account disciplinary action as it relates to retention incentives. There was disciplinary action taken. It was our judgment that in order to continue to turn this ship, that it's important that the department have the ability to retain executives that we think are turning the ship in the way that it needs to go. We do that very carefully. I want to convey to the committee that this is done with a lot of care and concern. It's done with fiscal stewardship, and it's done in an effort to keep a highly qualified workforce in place.
Well, you've obviously got the patience of Job, because this has been a 4-year trail to lead us to where we are at today. You saw the performance metrics that the chairman showed earlier. They're headed south, and yet you're maintaining your steadfast support for the leadership that's in place. Back to your commercial experience. Would you have been able to recommend to your CEO performance incentives and bonuses for executives that were not meeting their performance standards? I can tell you what the answer was in my company.
Yeah. Sir, let me again clarify. There was no performance bonus paid.
No, a retention bonus.
And that was based on performance.
What is a retention bonus?
A retention incentive is a tool that is available in government to keep highly qualified individuals.
Highly qualified?
Yes.
Which would insinuate that they're meeting their performance standards, correct? At least meeting their performance standards, because again, I worked in the federal government, so I know what the civilian employee performance standards are.
I think the thing that I would like to convey, and Mr. Weaver can speak to this and Ms. Barracall in more detail, we are improving care at Miami. We are continuing to make progress with the performance measures. And that is what is in the best interest of veterans to provide care. Are we there yet? No, sir, we are not. And when you stopped me earlier in terms of our continuing to evaluate, I can assure you we do a day-by-day evaluation of our leadership.
Okay, well, something that I think our
I
veterans...
assure you we will make decisions that are in the best interest of care.
All right, well, I think our veterans are going to expect that. They have a right to expect
Yes,
that.
sir, they do.
How long does an admonishment stay in an employee's record?
2 years. I'm sorry, I have to...
Is it punitive?
It is a form of disciplinary action, yes, sir.
Is it punitive? Does it cost them anything? Is there a suspension? Is there
It's a level of
reduction in salary?
No, it is an admonishment. There are different levels, and let me also explain the process by which the level of disciplinary action is rendered. When there is administrative action proposed, that's in the hands of the person who has responsibility for that person. We go through a process whereby General Counsel and the Office of Human Resource Management review the fairness and justice and the supportability of the action. And that was done in this case with the 2 people from the National AIB. And we monitor that continuously. We're looking at continued ways in which to improve that process, but it is done in a very deliberate way that tries to provide fairness and justice for the individual, but also holds the executive accountable for performance.
Did you initiate the letter of admonishment, or who did that?
In the case of Ms. Bearcall, that came from Mr. Weaver, comes from the direct report, and in the case of Dr. Vera, from the medical center, chief of staff.
Okay, well, like I said, I think our veterans deserve better. I think they expect better. And we've got a lot of questions that have been asked and answered here today. And Mr. Chairman, I'm even more concerned leaving the hearing than I was before I came in. I yield back.
Mr. Weaver and or Ms. Bearcall, is the domiciliary facility still going to be built in Miami as was originally planned?
Okay. The answer to that is not as originally planned. We had difficulties with the county commissioners in Broward County. They had voted it down. What we have done as an alternative is to expand the scope of the domiciliary that's going to be built in West Palm Beach on the campus there, and we will be expanding that for southern Florida. Once we have that expanded, then we can make an assessment of whether we need to go further into Miami to have into Dade County to have a second domiciliary or some expansion for that.
Can you tell me why there have already been employees hired for the domiciliary now that is not going to be built in Miami, but apparently in Palm Beach? Why were they hired, and now what happens with those individuals?
Okay. First of all, the reason they were hired is that as we were planning to open the domiciliary, we part of the rationale working in a central office, they said that we need to bring staff on so that when the domiciliary comes live, that we would be able to move those employees into the domiciliary and have them start working. And Ms. Bearcall can talk a little bit about what they've been doing in the interim.
Well, why don't we do that? Because I'd like to know, since there is no domiciliary, what have they been doing and what will they be doing?
Okay.
And Ms. Bearcall?
Certainly. We were asked to have the employees in place by the month of June, I believe it was, and so we proceeded to hire the individuals. Because the domiciliary would be a new program. It required a lot of policy development and just determining how the program would run. Since the domiciliary, the area where we were going to build, the commissioners did not agree to allow the veterans the veterans program to be in their downtown area.
We didn't, I mean, you didn't know beforehand. I mean, we've hired people, we've done planning, we've done engineering and all of the things that are necessary and had no approval from the local governmental entity as to whether or not it met with zoning and codes.
We had been requested to hire from the program office. So
Where's the program office?
In central office.
Okay, so it's up here.
So, sir?
So it's in Washington.
Yes, sir.
All right.
So
It goes around the VISN, not through the VISN, but around the VISN directly to you.
no, everything that we do everything that we do pretty much goes through the network and then to Washington, and we have a very very fluid communication between the three groups. So these individuals, what we have done at the time is the director of the DOM is a social worker at our facility, and he has been assisting with developing the new proposal that is being submitted for West Palm to have their domiciliary. And some of the other individuals that were hired, I am able to absorb within our needs at the medical center.
So you have one, but how many people have been hired?
I don't remember the exact
10?
number. I don't remember the exact number, but it's probably like
21?
I don't remember the exact number. However, what I can tell you is that we've looked through the list, and on the number of individuals that have been hired, that we can absorb within vacancies of the medical center as opposed to going out and hiring wherever we had those needs. And some of the other individuals are continuing to help in the development of policies and that kind of thing, so that the new proposal can go into place.
Mr. Baracol, I'm going to ask a question. It involves a particular employee, but I think they're far enough out of somebody's reach that it should not create a problem. But I've gotten information regarding some email accounts that may have been confiscated. And I just want to know, have you ever confiscated somebody's email account? If you did, can you describe how you did it, what the policies are within VA, and, you know, I just am concerned that policies continue, even things like emails, even though they're on a government system. Isn't there a policy in place as to how you lock somebody out of their system and don't allow them to have access again?
I think you're referring specifically to the actions that might have been taken with a public affairs officer.
So the question is...
So that I can address it specifically.
Yes.
We're talking about that?
Yes.
So at the time, there were, this happened during the time of the endoscopy.
Were you authorized to confiscate their email account? And if you did, were they ever allowed to reaccess their email again?
My recollection of the situation, the individual had compromised, or it was our understanding at the time that they had compromised the medical center, and what we did was we did look into the emails. There is as a public officer, there is no privacy in terms of the communication.
That's not what I asked was, I mean, I understand, but is there not a procedure in which you can take over somebody's email account, and you're saying it was because they had compromised the medical center's integrity?
Sir, this is approximately 3 years ago. And what I would like to do, if at all possible, is request if I could speak offline with you at some time once I review that folder again.
That would be fine, but in communications with this individual's attorney, all 17 accusations have been proven false. All of them.
The individual, there was a proposed action on this individual. What I can say is that that the individual sought assistance from another individual to move at their choice to move voluntarily outside of the Miami VA Medical Center and be transferred to another facility. So there was a proposed action and a decision made on the proposed action, and the individual consulted with another facility director to request a transfer into that facility prior to the actions being taken.
So this person was accused and just left the facility?
There was a proposed action
Proposed by
myself, and I had made a decision based on the evidence that had been developed.
And that proposal was to shift this individual to an off-site location, totally stripping them of their original job, and they have now been separated from their family were separated for some 2 years from their family. All accusations, as you know, have been proven false. There's never been a shred of evidence. And my question is, how do you make an employee whole when you charge them with something and it doesn't hold up?
Sir, there was a proposal to an action, and then the evidence was, we had whatever evidence we had to support the actions as they were proposed, and then as I reviewed the evidence, then made a decision on the action. The individual had consulted with another facility director who then made the decision to transfer her prior to the decision being implemented. So it was a decision that was made outside of my scope. I was not aware of it. I did not transfer her to that facility. And as a matter of fact,
if you were a trained public affairs officer and you were used to dealing with the public and you were stuffed somewhere inside of a closed office and not allowed to interact with the public, you were just making telephone calls, wouldn't you want to get out of that environment?
What I indicated...
Don't make it out like she did this because she just decided she wanted to transfer a long way away from her family.
What I would like to say is that every employee has the opportunity to present their side of the story before a decision is made, and the due process is provided, and the time when the individual was moved from the facility was exactly during the time of the endoscopy. I had requested the individual to do certain things and they were not done. It was a very critical time for the medical center, and I needed everybody on board and everybody following directions and doing what we needed to do to address things in the best interest of the veterans.
So this has nothing to do with collaboration or anything. I mean, you just didn't do what you wanted her to do.
Sir?
She just did not do what you wanted her to do?
The individual was my direct report. We were trying to handle a crisis at the medical center. I needed everybody to follow directions and not to go in their own direction. It was important to have everybody, as the leader of the organization, it was important to me that everybody was following directions.
So you took a leadership role, removed her from her position, put her in an environment that you knew she would not be able to do what she wanted to do, and then you represent to this committee that she just decided to transfer on her own. No?
No, that's not what I am proposing, but I really would like to vet the details of this situation.
No, that's what this hearing is about. So offline, online, you know,
Okay.
okay. We'll do it
It's
offline at another time, and
not-
we'll do it offline at another time, and I'm very appreciative of the candor. Mr. Schoenhard, I have great respect for you. No, I do. And I know the things that you have said today you mean, and I can appreciate that. But I am so saddened. I am so saddened by what I have heard today. Things that are going on at the Miami VA Medical Center that are atrocious. And if it's better today, I can only imagine. No, ma'am, we're done. I can only imagine how bad it must have been if you think that it is moving in the right direction. Somebody has to be held accountable, and it hasn't happened. People are scared to death of the director. They are scared to tell the truth. Why? Because they'll be stuffed in a box somewhere in an office with no windows, making phone calls to veterans in an attempt to get them to leave on their own so that it can't be said that they were forced out. I intend to talk to some employees at the facility. And I can only imagine what I will find when I directly engage with the rank and file at that facility. Because if there's even one shred of evidence that we've proposed to you today that is true, the director should not be the director, much less be given a retention bonus. And by the way, on September 1st of this year, I wrote a letter to the Secretary, which it has not been responded to yet, in regards to VA using this money for retention bonuses, especially for people who we know are going to be retiring in the future. And so I appreciate all of my colleagues being here today to talk about a very important issue. And no, I don't use a broad brush to paint the entire VA system, because I know that there are dedicated, hardworking individuals at every level of the VA that are taking care of our American heroes, because we owe them nothing less. And I am sad today. With that, we're adjourned.